Hi, good afternoon. I am Dr. Sangeeta Agrawal, gynecologist, practicing in Mumbai, in Prabhadevi area, and I'm attached to various hospitals in South Mumbai. So here I am, available for answering questions that you may have regarding any gynecological topic or obstetric topic. And today we will also discuss a bit about labor. So, please pardon my weekend look. We have been at home for almost a week now, and it is almost becoming impossible to remember when it is a weekday and when it is a weekend. So, every day feels like Sunday, and hence the Sunday attire. Let's discuss labor. Labor is one moment, but that time in life when all women look forward to, but have a lot of fear and lot of anxiety, lot of questions. Everybody knows it's a natural process, but yet when you think of it, you have lot of anxiety. So what are the three important symptoms of labor? The three important symptoms are pain, leaking, and show. These are the three important symptoms. So what is the pain like? The pain is very typical in labor. Of course, at times it can be confused with other kinds of pains, but this pain typically starts from the back and migrate comes towards the front and towards goes down towards the pelvis. The pain is a contraction, is like a squeeze which you feel, and it gradually increases in its frequency, intensity, and duration. So, what I mean to say is you may have one contraction every 20 minutes, and then gradually it will become two contractions in 20 minutes, and then three in 20 minutes, so on and so forth. It will gradually increase in intensity and in duration. The first few contractions may last only for 10 to 15 seconds, but slowly they will gradually increase, and each contraction may last almost up to 30 to 40 seconds. They, as labor progresses, they increase in their intensity, duration, and frequency. The next symptom of labor is show. So, what is show? Now, in the cervix, there is a mucus plug. This plug thickens over the period of 9 months, and it stands like a bodyguard at the neck of the uterus in the cervix because it is so thick that it prevents the entry of bacteria and sperms inside the sterile uterine cavity through the 9 months when the pregnancy is inside. At the time of labor, sometimes just before the pain starts or after the pain starts, a woman may complain of a very thick, mucousy, sticky substance which comes out from the vagina, and it may be streaked with blood. It may have streaks of dark brown blood or it may have fresh red blood, and it can be sometimes quite copious. So this is the show, and this is the discharge of the mucus which was lying at the entrance of the cervix. The third symptom is leaking. As you know, the baby is in a is surrounded by what liquid which is called as liquor, and it is covered by a membranous bag, and that bag is within the uterus. So during labor, the membranous bag sometimes ruptures. It can rupture before labor starts, or commonly it will rupture after labor. This liquor comes out, and it is a liquid substance which looks like maybe colorless, maybe whitish. It can sometimes be greenish also because then it is mixed with meconium. It is flaky because it has the vernix caseosa, the white sticky substance which is there on the skin of the baby, which may be mixed with this liquor. So if the liquor is copious, it is whitish in color, flaky, and it has a unique smell, then it is all normal. If it is greenish in color, it means that there is some meconium, but it has to be interpreted with respect to various factors, and Only then we take it whether the meconium means anything or not. So these are the three main symptoms. Now, these three symptoms are actually leading to the three most important processes which are happening in your body during labor. So the three most important processes is with the contractions, with the labor pains, is dilatation of the cervix, effacement, and descent of the fetus. So what do I mean by effacement, dilatation, and descent? As you know, you have to do a little bit of imagination. The uterus is a structure which has my palms are the cervix, and this area enclosed is the uterus. So dilatation is opening up of the cervix like that, but the cervix does not really open in this manner. The cervix is slowly stretched, and the cervix becomes one with the body of the uterus, and this process is called as effacement. So this process is called effacement, and then the cervix opens like that, and it is called as dilatation. These are happening gradually. Effacement and dilatation happens in simultaneously, and the descent also happens as the baby comes down in the passage of the vagina. So labor has two phases. Once it starts, there are two phases. It is called latent phase, and there is an active phase. Sorry, before I go ahead with this, I must mention that when labor starts after 37 weeks of pregnancy, it is called as full term, and that's when ideally labor should start. When it starts before 37 weeks, it is called preterm labor. Today, I am only discussing labor which is at term. So, labor has two phases, the latent phase and the active phase. Now, if we were to do an imagination, we say that the neck of the uterus has to open up to 10 centimeters. So, the process from 0 to 3 centimeters is the latent phase, and anything from 3 centimeters to the 10 full dilatation is the active phase. The latent phase can last from a few hours to a few days and sometimes a week or so. Women may complain that they have a lot of backache, they have discomfort, they don't feel quite good, and they feel some uneasiness down below, and they may be having mild contractions which are making the cervix softer, helping it to open up a little bit and efface out a bit. So that process is the latent phase. For some women, the latent phase may just last a few hours. Once you are 3 centimeters, once you are few centimeters, 3 centimeters, then after that, the whole progress of labor should go along the pathogram, which means by and large, a primary would take about 8 to 10 hours, and a multigravid patient would take about 6 to 8 hours. And there is a curve along which is plotted on a graph where you say the dilatation and the time taken, and the whole curve should then follow the normal curve, and it should not go to the right of the curve, because in that case it would mean that the labor is slowing down and sometimes action is required. A few more points on labor. So this is the three symptoms: the pain, show, and leaking, and the three processes: the dilatation, effacement, and the descent. Now, when there is a descent of the fetus happening, it goes through the whole pelvis. There is a rotation which takes place. The head of the baby can be placed in the pelvis in various ways. Now, again, you need to do some bit of imagination. If you have a round ball and you imagine the nose, when the baby's head is down in the pelvis, if the nose is pointing to the back on the right side or the left side, that is called as a left occipito-anterior or the right occipito-anterior position, then it is one of the most favorable positions. Sometimes the nose can be pointing right to the left of the woman or to the right of the woman, and that is a transverse position. And if the nose of the fetus is pointing to the diagonally in the front, either the left side or the right side, then that is called as the right occipito anterior and sorry, the right occipito posterior and the left occipito posterior positions. And if the nose of the fetus is pointing to the right into the front of the mother, then it is called as the occipito posterior positions. The right occipito, left occipito posterior and the occipito posterior positions can be difficult, lead to difficult deliveries. Then there is a situation where description is based on how the neck of the baby is with respect to the chest. Is it a deflexed head or a flexed head, like that, with the chin of the baby touching the chest of the baby? If the chin of the baby is touching to the chest, it is um, the correct favorable position. Now, we also use the word as station with respect to the ischial spines, and as the baby is descending down and when the doctor does an internal examination, he is checking what is the distance of the baby with respect to the ischial spine. The higher up it is through the ischial spine, it's some time to go. And when it comes below the ischial spine, then the station is said to be more than plus zero. So the station is defined with respect to the ischial spines, and that is something that the doctor does understands when they do an internal examination. So when you're in labor, it's a your baby is a passenger and the vagina is the passage. So this passenger has to go through this passage. This is a journey to be done, and the contractions of the uterus are the propelling factor. And as the baby comes down, the dilatation effacement happens, and the baby is passes through the vagina. The second stage of labor is said to have started when the cervix is fully dilated, and then the descent of the fetus happens through the passage. And the third stage is when the baby has fully delivered, and then we are waiting for the placenta comes out. So after the delivery of the baby to the delivery of the placenta is the third stage of labor. Now, once you get it, what should you do? If you have the pain, the show, and or leaking at home, you need to inform your gynecologist or the hospital or nursing home that you have been registered for delivery. And I'm sure you have already been given a whole set of guidelines on what you should be doing, packing your bags, taking all your reports, your files, etc., and getting to the hospital. Once you are in the receiving room, you will be received by a doctor or an assistant of the doctor or the midwife. They will do all your preliminary testing, and then you will be admitted into the delivery room where you will undergo further processes. Uh, so there is a monitoring for the mother and there is monitoring for the baby. You may be allowed to eat and drink in the initial phases of labor, and subsequently you will be told to only liquid diet. And there will be sometimes a situation when the doctor tells you that it is not, we would like to keep you nil by mouth, because if we foresee a situation where you might need a cesarean section, then under those circumstances, the doctor will give you a intravenous line and tell you to avoid eating and drinking. As the pain builds up, you can be offered epidural analgesia if it is available in your setting. It is one of the, according to me, the best things to happen to women, because you can then be as good as pain free and enjoy your labor and look forward to that big moment where you will be holding your bundle of joy in your hands. So uh, it is advisable to have a detailed discussion with your gynecologist in your antenatal period about epidural analgesia and all other forms of analgesia that is available in labor, so that you can make a conscious decision on what you would like to do when you go through this special time in your life. So you can be prepared for epidural, and then there will be times when there is monitoring done by recording the baby's heartbeat. That is called as CTG in labor. So that gives us a recording on what is the baseline heartbeat of the fetus, how much variability there is, and how the heartbeat of the fetus responds to the contractions. In case during the contractions there is a drop, but the heartbeat recovers very quickly, then it is nothing to be concerned about. But in case the heartbeat drops during the labor and during contractions, and then if it does not come back to normal quickly within the next 30 seconds or so, but takes longer, then in that case it could be a reason for concern, and again the doctor would need to examine you and decide on the next step. So you would undergo the routine checks as well, like your pulse, blood pressure, temperature, the CTG, and regular vaginal examinations to decide the progress of labor. Once you are ready, it depends on the situations. It can be different in various hospitals. Sometimes you are shifted to a labor room, which is another designated area for delivery, and there are some times when you could deliver in the same room as the labor room. So it really depends on what circumstance, what kind of hospital you are in, and what is the setup in that area. In either way, either case, you will either be looked by a midwife or your gynecologist, who will then be ready with a delivery trolley, etc. So that, and in most cases, especially in tertiary hospitals and in big metro cities, we would always have a pediatrician available who would be attending the delivery so that they can look after the baby as soon as the baby is born. Now, another big question, big fear is, what is episiotomy and will I am going to have one? Well, there are multiple reasons when an episiotomy is given, and there are multiple reasons when it is not given. I will not go into the details of that today, but just in case you have an episiotomy, let me explain what it is. When the fetus is right down onto the perineum and ready to come out, and there is crowning, that means you can see a part of the head of the baby at the vaginal opening, then the doctor can give you a little local anesthesia if required, and then give you a cut on the perineum. This makes it a little easier for the fetus to deliver. And of course, in case there is some difficulty in the fetus coming up, delivering, then if the doctor needs to apply a forceps or a 1-2 to the head of the baby to deliver, to do an assisted delivery, then it is feasible to do that. Of course, we take care to ensure that you have passed urine and your bladder is empty at that time. Once the baby, so the cut is given, and once the fetus delivers, then the cords are clamped, the cord is cut, and the fetus is handed over to the pediatrician to be looked after oropharyngeal suction. And we then wait for the placenta to deliver. Sometimes the doctors may give you some uterotonic agents, which will help in the separation of the placenta and for it to come out. Once the placenta comes out, the uterus starts retracting, and the bleeding is controlled. Then the doctor watches to make sure that there are no cervical tears, examines the vagina to see the apex of the cut, and then the episiotomy is sutured by the gynecologist using various different materials, but by and large they are all absorbable material. And once that is done, you may then be given you will then be given some analgesic and maybe some antibiotics. This again is variable depending upon where you are. And Soon you will then, after about half an hour, 1 hour of observation, you will be shifted back to your room. Of course, during this time, where some the pediatrician will also assist you whilst you're in the delivery room and undergoing the episiotomy, and assist the baby in latching on to your breast, if that is a desire which you have already expressed. Once you are in your room after about 2 hours and your pulse, blood pressure, everything is stable, there is no active bleeding, or then you will be allowed to eat and drink. Again, what you eat and drink will be dictated by the local circumstances, what is available as per various customs and religious options. Uh, Guidelines are as per your customary and social background. You are allowed to eat and drink. So, you can look forward to labor. There's nothing to be worried about. Good analgesia can make you actually enjoy labor, and close observation and timely action by the gynecologist can make the whole process result in a bundle of joy in your hands. Now, I think I have spoken quite a bit, and if you have any questions, I will be happy to answer. Okay, somebody wants to know. I will explain the situation of induction of labor. What is induction? So, there are certain circumstances or medical grounds in which a doctor may feel that it is important to deliver the baby, because the intrauterine environment is not conducive for better growth, and the baby may be better off outside. And therefore, labor is actually started by various means. So you can be given certain medications in the form of tablets under the tongue, or tablets which are inserted in the vagina, or there are some gels which are put into the vagina. All of these are given with an intention to start contractions in the uterus, or, which subsequently will convert into the process like a natural labor, cause effacement, dilatation, and descent of the fetus. One such example is when the mother is having high blood pressure at term, and there is reasons to consider to bring hasten up the delivery process. Inductions are also done when the woman crosses 40 weeks and she is in her 41st week, and labor has not started on its own. So that is induction of labor. What is augmentation of labor? Augmentation of labor is when the process of labor has started on its own, but uh, when you are monitoring the labor, you sometimes have a situation where the process is a little slower, and you feel that the contractions that the patient is having are not strong enough, or not frequent enough, or not lasting long enough. Under those circumstances, the patient is given certain medications. Usually, it is an intravenous infusion, and those, because they can then be very closely monitored. And the contraction, we want to increase the intensity or the duration and the frequency of the contractions, so that the labor becomes more orderly and progresses faster. Of course, this has to be done very judiciously, because we do not want a situation where the contractions are too many and too long and almost suffocating the baby. And at the same time, we don't want contractions which are too light and are not resulting into any descent. So it has to be done, monitored very well. So that is about induction and augmentation. Of course, there are certain risks, and any patient who is ever had a cesarean section in the past should never undergo any augmentation and induction. If a patient with a previous cesarean section has needs a delivery, then she would probably need an elective or a planned cesarean section. In the same context, it is very important to realize that breech presentations, transverse lies, all these conditions, it is not possible to do induction of labor, and they are candidates for planned cesarean section. So, any questions on labor? Well, I intend to be here again tomorrow evening at 5 o'clock, and I request the viewers that you may feel free to write in your suggestions onto our Facebook page what topic you would like us to cover. But tomorrow I may cover contraceptive methods or continue with the labor discussion. We will inform our topic by tomorrow, but you are feel free to send in your suggestions. With this, I'd like to say goodbye for today. Thank you. It is a pleasure to do these sessions, and I hope you enjoy them. Uh, we look forward to your viewership even tomorrow. Till then, stay safe, stay happy, take care of yourselves. Thank you.